Now we're going to start talking about asthma and chronic obstructive pulmonary disease medications. There are approximately 6 classes of medications that work by different mechanisms of action in the treatment of patients with asthma and COPD. Each of these groups are discussed in detail for the treatment of asthma, and then specifically we'll talk about COPD. These drugs are also used in the treatment of other respiratory disorders that cause inflammation and bronchospasms, so you need to be familiar with them as well. They're usually delivered by inhalation and are designed for long-term controlled medications such as inhaled corticosteroids, long-acting inhaled beta-2 antagonists, leukotriene modifiers, theophylline, mast cell stabilizers, and also the quick relief and other medications such as rapid-acting inhaled beta-2 agonists, oral corticosteroids, and anticholinergics. The practitioner should help design a treatment plan for their patient that includes the components of therapy that provides direction for the treatment of symptom exacerbations. They also need treatment for maintenance. Detailed and ongoing patient education is required for adequate management of these diseases, and new medications are frequently coming out, so you need to keep abreast of these medications. The standards of care for patients with asthma were developed initially by the National Asthma Education and Prevention Program, as well as updated by expert panel report. Additional guidelines have been set forth by the Global Initiative for Asthma, Global Strategy for Asthma Management and Prevention, and both sets of these recommendations are based on a step approach that is bi-directional. Guidelines for standard of care management of COPD is often found at the National Heart, Lung, and Blood Institute, World Health Organization, GOLD, which is the Global Strategies for the Diagnosis, Management, and Prevention of Chronic Obstructive Pulmonary Disease, and these are great sources of information. So we're first going to start talking about asthma. Asthma and COPD are similar in their chronicity and in the terms of their obstructive component. However, asthma differs from COPD in that asthma is largely an inflammatory condition and has a greater degree of reversibility than COPD does. Drug therapy has not been shown to alter the long-term decline in lung function that occurs in COPD, but should be used to control symptoms. Therapy in COPD is also based on a step approach, but is unidirectional and cumulative. Although the same drugs are used in treatment of these disorders, asthma and COPD are often discussed separately because responses to pharmacotherapy differ. So first we're going to start with talking about the beta-adrenergic agonist bronchodilators. The beta-adrenergic agonists are synthomimetics. The basic action of these beta-agonists is to activate the enzyme adenyl cyclase, which increases the production of cyclic adenosine monophosphate, CAMP. Intracellular CAMP inhibits phosphorylation of myosin and lowers intracellular concentrations of calcium. The result of lower concentrations is smooth muscle relaxation. Bronchodilation reduces airway resistance, as shown by increased forced end volume, mid-expiratory flow rate, and vital capacity. Increased CAMP also inhibits the release of mediators from mast cells in the airways, thereby producing a mild anti-inflammatory effect. Non-selective beta-2 adrenergic receptor agonists and, to a lesser extent, the selective beta-2 adrenergic agonists cause reflex tachycardia. This produces arterial dilatation that results from beta-2 receptor stimulation of the heart. Albuterol and the other bronchodilators that are relatively beta-2 selective have the greatest effect on the beta-adrenergic receptors in the bronchial, uterine, and vascular smooth muscle. Bronchodilators developed to date are only relatively selective in stimulating beta-2 receptors, and all have varying incidences of cardiac side effects and muscle tremors. At high doses, the selective drugs may lose their receptor selectivity and also cause beta-1 stimulation. For this reason, you need to be cautious in using these medications with patients' cardiac disease. The role of rapid-acting inhaled beta-2 agonists, also known as short-acting beta-2 agonists, SABAs, in asthma therapy is to provide relief of bronchospasms during exacerbation or pre-treatment before exercise. These short-acting and long-acting beta-2 agonists are considered first-line drugs in the treatment of both asthma and COPD. Increased use of the short-acting beta-2 agonists may signal the need for additional drug therapy. Inability to achieve an adequate response with the beta-2 agonist during an exacerbation may indicate the need for the addition of a short-term corticosteroid, inhaled or oral. Nexanthines promote bronchodilation by competitively inhibiting phosphoesterase, the enzyme that degrades the CAMP, which in turn increases intracellular CAMP. Methylxanthines also act as a direct central nervous system stimulants that produce vasoconstriction and stimulation of the vagal center, which causes bradycardia. Methylxanthines in large doses have a positive inotrophic effect on the myocardium and a positive chronotrophic effect on the sinoatrial node, causing transient increases in heart rate, force of contraction, cardiac output, and myocardial oxygen demand. At high concentrations, vagal stimulation is masked by increased sinus rate and may result in hypotension, extrasystole, and arrhythmias. Additional effects of methylxanthines include diuresis through dilatation of renal arterioles, increased cardiac output, and inhibition of reabsorption of sodium and potassium in the proximal renal tubules. The gastrointestinal system is also affected by relaxation of smooth muscle, causing reduced lower esophageal sphincter pressure and released biliary contraction, along with stimulation of gastric secretions. The role of theophylline in the control of asthma and COPD is not a primary one because studies have shown that it is not as effective as inhaled long-acting beta antagonists or corticosteroids. It may be beneficial in some cases when given as an add-on therapy. Theophylline was used for many, many years in the treatment of asthma, but has been somewhat phased out for these reasons. The anticholinergics blocks acetylcholine-induced stimulation of cyclic guanyl cyclase, thus reducing the production of the cGMP, or the cyclic guanosine monophosphate, which is a mediator of bronchoconstriction. So if you reduce this enzyme, then as being a mediator of bronchoconstrictions, it's going to reduce this effect. Similar to atropine, anticholinergics are non-selective competitive antagonists of serotonergic receptors present in the airways and in other organs. The anticholinergic drug blocks acetylene-induced stimulation, thereby reducing the production of the cyclic guanosine monophosphate, the mediator of bronchoconstriction. Airway secretions are reduced by these drugs, as well as airway resistance, as measured by increases in the FEV1 in the middle portion of the forced expiratory flow. Ipratropium and tiotropium, when inhaled, may be more effective in COPD than in asthma because it's believed that cholinergic tone of the airways is increased in COPD. Thus, these anticholinergics are more effective. They exhibit greater antimucinergic effects on bronchial smooth muscles than on secretory glands, especially with oral inhalation of the drug. Additional effects may include mydriasis, inhibition of salivary and gastric secretions, tachycardia, and spasmolysis. However, clinical trials have shown that these effects are insignificant in healthy individuals and in those with COPD. Anticholinergics are often used as first lines as an adjunct or alternative to beta-2 agonist therapy to avoid those beta-2 side effects, and because they have a longer duration of therapy effect. For the mast cells stabilizers, these prevent and reduce the inflammatory response of bronchial walls by inhibiting the secretion of mediators from mast cells. The exact mechanism of action remains unknown, but these medications act locally to inhibit the release of mediators of type 1 allergic reactions, including the histamines and leukotrienes from the sensitized mast cells following exposure to an antigen. They inhibit type 3 late inflammatory reactions to a lesser extent. These drugs are anti-asthmatic and anti-allergic and are also can act as bronchodilators. The corticosteroids are hormonal agents that have a profound anti-inflammatory effect. They reduce airflow obstruction by reducing airway inflammation in the bronchioles. Corticosteroids modify the body's immune responses to various stimuli. They suppress cytokine production, airway eosinophil recruitment, and the release of inflammatory mediators. Inhaled corticosteroids provide local therapeutic action with minimal systemic effects. They're shown to reduce asthma symptoms, improve the quality of life, improve lung function, decrease airway hyperresponsiveness, control airway inflammation, reduce frequency and severity of exacerbations, and reduce asthma mortality. Oral corticosteroid treatment is often indicated for exacerbation of asthma and in some cases of COPD. Inhaled corticosteroid therapy in COPD does not alter the course of the disease, but it does control symptoms and has been shown to reduce the frequency of exacerbations. The leukotriene modifiers act on an inflammatory mediator of asthma. They also known as slow-reacting substances of anaphylaxis, which contribute to airway obstruction. Cysteinol LTS or CYS-LTS are more potent and longer-acting bronchoconstrictors than histamine. They produce a variety of cells such as eosinophils, mast cells, basophils, macrophages, and monocytes from arachidonic acid through several enzyme pathways. Arachidonic acid is released from cell membranes in response to the antigen-antibody reaction, the immunoglobulin IgE receptor activation due to microorganisms and physical stimuli. The leukotriene modifiers enhance responsiveness to the airways to a variety of stimuli and stimulate secretion of mucus in the airways. They're potent competitive leukotriene receptor antagonists and block the action of CYSLTs at receptor sites on smooth muscle cells throughout the bronchioles. A single type of receptor is able to mediate profound contractions brought about by these CYSLTs. Leukotriene modifiers prevent the binding of the receptors in the airway, thereby blocking bronchospasms. They may be used as an alternative to inhaled corticosteroids in patients with persistent aspirin-sensitive asthma, but their effect is weaker than that of low-dose inhaled corticosteroids. Thereby, they're usually used as add-on therapy for asthma. So, cardinal points of treatment for asthma. The goal of therapy is to gain and maintain long-term control of asthma and quickly and successfully treat asthma exacerbations. Control of asthma is defined as the prevention of chronic and troublesome symptoms, maintenance of normal or near normal pulmonary function, maintenance of normal exercise and activity levels, prevention of recurrent exacerbation, avoidance of adverse effects from drug therapy, and satisfaction of patient and family expectations for asthma care. Remember, asthma is a chronic inflammatory disease of the airways that requires daily use of a controller medication in most cases, even in young children. Only those with mild intermittent asthma, which is considered symptoms less or equal to 2 days per week or less or equal to 2 nights per month, require no daily medication. They can be treated as needed with the use of rapid quick relief beta antagonists. The preferred controller medication in adults and children with persistent asthma is low-dose inhaled corticosteroids. A leukotriene mast cell stabilizer may be considered as an alternative for long-term control. The addition of long-acting beta-2 antagonists for patients with moderate persistent asthma improves lung function and symptom control and reduces the need for quick relief of medications. Long-acting beta-2 antagonists used with corticosteroids increase the risk of serious adverse events and death in patients with asthma. Long-acting beta-2 antagonists should never be used without an accompanying corticosteroid. Alternatively, theophylline, or doubling the dose of an inhaled corticosteroid, may be considered for add-on therapy for those 5 years of age or older. For children younger than 5 with moderate persistent asthma, an increase in the medium dose inhaled corticosteroid given as a monotherapy is followed by the addition of a long-acting beta antagonist or a leukotriene modifier. Treatment of severe persistent asthma requires high doses of inhaled corticosteroids and long-acting beta-2 antagonists or leukotriene modifiers. A course of oral corticosteroids may be used in severe asthma, but long-term steroid use should be avoided if possible. Pulmonary specialists may consider new monoclonal antibody directed against IgE, but this is really the first biological therapy targeted for the use of treatment for asthma, for severe asthma, and then for those older than 12 years old. Quick relief medication, short-acting beta-2 antagonists, is preferred and may be used at all stages of asthma for breakthrough symptoms or exacerbations. Eproponium may be added for severe exacerbations. Urgent medical care for exacerbation should include inhaled oxygen. Adjunct therapy in refractory cases may include mechanical ventilation. Sometimes inhaled helium or oxygen mixtures may be administered. Referral or a consultation with an asthma specialist or pulmonologist is indicated if there is a difficulty in maintaining control in adults or children. Referral may also be considered if the adult or children older than age 5 or an infant or child has difficulty maintaining control. It's often a stepwise therapy in which you follow the plan. Step 1 therapy for adults and children 5 years or older with mild intermittent asthma involves a quick relief bronchodilator used intermittently with no long-term medication. Inhaled relatively selective beta-2 adrenergic agonist bronchodilators are preferred for all severities of asthma because of their minimal side effect profile. Step 2 therapy requires a long-term anti-inflammatory medication in addition to the quick relief bronchodilators. Choices of long-term control include the inhaled corticosteroids in low dose, a mast cell stabilizer such as a leukotriene modifier, or possibly oral theophylline. Step 3 therapy distinguishes between 5 to 11 and 12 and older age groups. For those 12 years and older, an inhaled corticosteroid at medium dose is as monotherapy, or an inhaled corticosteroid at low dose with the addition of a long-acting beta-2 antagonist is the preferred therapy. Alternative therapy is a low-dose inhaled corticosteroid given along with either a long-acting beta-2 antagonist, oral theophylline, or a leukotriene modifier. For those that are in the 5 to 11 years age group, any of the therapies may be used without preference. Step 4 therapy uses an inhaled corticosteroid at medium dose along with a long-acting beta-2 agonist. Alternatively, medium-dose inhaled corticosteroids plus leukotriene modifiers or theophylline is also given. Step 5 therapy calls for a high-dose inhaled corticosteroid plus a long-acting beta-2 agonist. Alternatively, in the 5 to 11-year-olds, a high-dose inhaled corticosteroid plus a leukotriene modifier or theophylline may be used. In the 12 and older age group, you can add the biologic medication used for those patients with allergies. Step 6 therapy calls for high-dose inhaled corticosteroids plus long-acting beta-2 antagonists plus an oral corticosteroid. Leukotriene modifiers, theophylline, may be substituted for a long-acting beta-2 agonist in the 5 to 11-year-old age group. Education and the use of non-pharmacological management accompanying every step of therapy is necessary for your patients. Non-pharmacological management involves controlling environmental triggers and using simple breathing techniques to help control airflow. Patients must identify and avoid the factors that trigger their asthma attack. Allergy skin testing is recommended to identify any outdoor or indoor allergies. Sinusitis, rhinitis, and gastric esophageal reflux disease should be optimally managed, and influenza should be prevented through the use of yearly immunizations. Early recognition and treatment of exacerbations of asthma are important in reducing the risk of death and helping to regain control of asthma. Asthma exacerbations are acute or subacute episodes of worsening shortness of breath, cough, wheezing, and chest tightness. Exacerbation can be determined objectively by measurement of a decrease in peak expiratory flow or forced expiratory volume. Ultimate treatment of exacerbations may involve short-acting beta-antagonists, systemic corticosteroids for those with moderate to severe asthma, or those who do not respond to inhaled corticosteroids. It also involves oxygen to relieve severe hypoxemia and close monitoring of responses through lung function measurements. Home treatment guidelines for asthma exacerbation are based on monitoring of symptoms or the peak expiratory flow measurements compared with personal bests or predicted peak expiratory flow. Asthma exacerbation should be treated with short-acting beta-antagonists as needed based on severity of symptoms. Up to 3 treatments should be used in a 20-minute interval. A written asthma action plan should instruct patients to initiate quick relief medications if the peak expiratory flow drops to below 80%. If the peak expiratory flow is 50 to 79% of a predicted or personal best, the patient should consider notifying their clinician. If a peak expiratory flow is 50% or below, immediate medical care is required and the patient should be brought to the emergency room. So for the cardinal points of treatment, bronchodilators are primary to symptom management as needed or scheduled use. The choice between short-acting, rapid-acting, or long-acting beta-antagonist, short-acting anticholinergics, and long-acting anticholinergics is based on individual responses, side effects, and access or ease of use. For COPD stage 1, PRN use of short-acting bronchodilators is indicated. For COPD stage 2 through 4, a long-acting bronchodilator should be added if dyspnea persists during daily activities. Regular use may be more effective and convenient than as-needed use. As-needed use of a short-acting bronchodilator may be prescribed along with the regular use of a long-acting or short-acting bronchodilator. Use of long-acting theophylline preparation is not well tolerated in these patients because of common side effects such as cardiac arrhythmias, headaches, insomnia, nausea, and toxicity, which may be induced by changes in metabolism caused by food and other drugs. Although past COPD guidelines have recommended a 2-week trial of oral corticosteroids to predict whether there will be a long-term benefit, the GOLD guidelines state that there is insignificant evidence to recommend this, even in severe cases of COPD. Regular use of inhaled corticosteroids is recommended for COPD patients stages 3 through 4, with less than 50% of predicted FEV1 to reduce frequent exacerbations. Influenza and pneumococcal immunizations are recommended to help reduce comorbidity that will affect respiratory status. Mucolytic agents may be considered as adjunct therapy. Exacerbations of COPD should be treated with increased dose and frequency of short-acting bronchodilators, systemic corticosteroids if the FEV1 falls to less than 50% of predicted, and antibiotics if purulent sputum develops. Most exacerbations are caused by infections, although infection may be viral, and about 1/3 of the exacerbations have no cause. There must be an assessment in the emergency department and possible hospitalization for those patients with severe exacerbations with respiratory acidosis, significant comorbidity, and the potential need for ventilatory support. Treatment should be supplemented with oxygen, an anticholinergic bronchodilator, inhalation via a spacer or nebulizer, and IV methylxanthine if insufficient response to short-acting bronchodilators, oral or IV corticosteroids, and possibly mechanical ventilation. Fluid balance, nutrition support, and deep vein thrombosis prophylaxis with heparin are supportive therapies. The gold standard guidelines for treatment of patients with stable COPD is based on severity and is provided in a stepwise approach, starting with one drug and adding drugs as severity increases. Treatment with medications alone does not effectively manage COPD, therefore non-pharmacological treatment strategies are also very important. The goals of COPD treatment are to help with symptoms, enhance lung function, improve physical activity, reduce long-term lung function decline, prevent and treat exacerbations, reduce hospitalizations and mortality, relieve disabling dyspnea, and improve exercise tolerance and health-related quality of life. Pharmacologic treatment does not change the overall long-term decline in lung function. Only smoking cessation can slow the progression to the rate of a normal age-related decline. Non-pharmacological strategies include smoking cessation, patient education, improved nutrition, and exercise. Pulmonary rehabilitation programs are typically multidisciplinary and include individualized, carefully monitored exercise programs, as well as patient education and support. Removal and avoidance of toxins such as cigarette smoke and air pollution are important goals of therapy. Pharmacological therapy of an adjunct nature includes immunizations yearly for influenza, pneumococcal immunization, and possibly mucolytic therapy. Every effort should be made to avoid exposing these individuals to upper respiratory infections, which often are carried by children. There are stages of therapy. Stage 1, for the stage 1 severity, COPD begins with short-acting bronchodilators as needed to control symptoms. Stage 2, therapy for step 2 therapy for stage 2 COPD involves the regular use of long-acting bronchodilators in addition to the as-needed use of short-acting bronchodilators. Pulmonary rehabilitation should be added during step 2. For those patients who need additional symptom control, a long-acting thiophalin may provide additional benefit. During step 3 therapy, for stage 3 COPD, adds an inhaled corticosteroid if exacerbations are repeated. Step 4 therapy for stage 4 COPD adds long-term oxygen therapy for those with chronic respiratory failure. Remember, these must be at low doses of oxygen therapy. Surgical options of bulectomy, lung volume reduction, and lung transplantation may be considered during this stage. Treatment for acute exacerbation of COPD includes increased dose and frequency of short-acting bronchodilators, along with the addition of an anticholinergic bronchodilator if one is not already in use. Inhalation via spacer or nebulizer may be preferred. Oral corticosteroids should be considered if the baseline FEV1 is less than 50% of the predicted and should be given to shorten recovery time, improve FEV1, improve hypoxemia, and possibly reduce the risk of relapse, treatment failure, and length of stay. Dosage of 30 to 40 milligrams per day for 7 to 10 days is considered effective and safe. An antibiotic that covers the most common causative agents, which include Haemophilus influenza, strep pneumonia, Moraxella catarrhalis, and possibly Mycoplasma pneumonia, as well as chlamydia pneumonia, should be added if purulent sputum is present. If the patient is not in respiratory acidosis and is not in need of ventilatory support, home management with frequent follow-up and monitoring may be appropriate. If improvement is noted on reassessment, this regimen can be continued and stepped down when possible. If hospital management is necessary, oxygen therapy, IV methylxanthines, IV corticosteroids, and ventilatory support may be necessary. Now we will talk briefly about smoking cessation, cardinal points of treatment. Just remember, any brief advice on smoking cessation can be successful. Pharmacotherapy is recommended unless contraindicated. The first line is nicotine replacement therapy, bupropion, varenicline, and second line includes clonidine and nortriptyline. Nicotine replacement therapy does not improve relapse rate, but some patients will relapse regardless of whether they use nicotine replacement products with or without counseling. The drug overview: nicotine replacement therapy includes nicotine antidepressants and nicotine receptor agonists. Mechanism of action of these drugs: when patients commit to stopping smoking, they often feel a loss of control of their lives. It may be helpful to describe different forms of smoking cessation therapy and have them select the mechanism that they feel will work best for them. Nicotine replacement therapy is often especially good for patients who are heavily dependent on nicotine and who smoke more than 2 packs per day. However, nicotine replacement therapy may be offered to most patients as an option. Make sure the patient receives an adequate dose. One of the main reasons for failure is underdosing. Another cause is incorrect use of the product. First, help the patient choose a dosage form that will work best for them. The patch is usually best for patients who smoke at regular intervals. Gum may work better for patients who smoke at irregular intervals. The patch offers more convenient once-a-day application, whereas gum offers more direct control of the amount of nicotine the patient receives. The gum can be used when patients have a craving. There's also the nasal spray, which is useful for responding quickly to cravings. The nasal spray is especially beneficial for highly dependent smokers. The inhaler mimics the act of smoking and will be useful for patients who enjoy handling cigarettes. Conversely, this technique may interfere with the need to change behavior, and patients eventually will have to learn to break the habit of handling something if they are to be successful. The inhaler is also useful when gum will not work because of concomitant consumption of acidic foods or beverages, alcohol, or coffee. Social occasions involving alcohol are often especially difficult for patients, and the inhaler might be the most acceptable form in this situation. Gum might be more acceptable at work. Patients who have stomach ulcers or diabetes should not use gum or lozenges, but may use the patches. However, patients who have an allergy to adhesive tape or pre-existing skin problems should not choose Nicoderm CQ or Nicotrol. All replacement products are meant for those who smoke more than 10 cigarettes per day. Nicorette 2 milligrams is used for those who smoke fewer than 25 cigarettes per day. 4 milligrams is best for those who smoke 25 or more cigarettes daily. Commit lozenges are used use a different index for the initial choice. Those who smoke their first cigarette more than 30 minutes after waking should begin with the 2 milligram lozenger, and those who smoke their first cigarette within 30 minutes of waking should begin with the use of 4 milligram lozengers. Bupropion as a systemic medication seems to reduce the craving for cigarettes or the urge to smoke. Its mechanism of action is not clear. Side effects include nausea, insomnia, tremors, and difficulty concentrating. They should be started 1 to 2 weeks before their quit date. 100 milligrams per day should be given orally for 3 days and then increased to 150 milligrams twice a day. You should continue this dosage for 7 to 12 weeks, and then the dosage should not exceed 300 milligrams per day. Treatment for longer than 3 months usually is not necessary, and dose tapering is not needed. Bupropion can be used in addition to nicotine replacement products and may be especially useful in patients who are somewhat depressed because the chemicals are the same as for the depressant formulation. Varenicline is the newest drug. Safety and effectiveness in combination with other smoking cessation medications has not been established. Results, however, from comparative trials with bupropion have shown similar efficacy with a slight trend toward better outcomes. Common side effects include nausea and abnormal dreams, which may limit acceptance by patients. The FDA has issued an alert to providers to monitor the patients who are taking Chantix for depression, severe mood swings, abnormal dream states, and thoughts of suicide. Again, the patch is the most commonly used type of nicotine replacement therapy. It's convenient with few compliance problems, and no special skill is needed for its use. Patches are easily concealed under clothing and cause few side effects. However, they deliver the nicotine slower than other forms. Also, allergic reactions to the patch can occur. The nicotine transdermal system is multi-layered that contains nicotine as an active agent that provides systemic delivery of nicotine for 16 to 24 hours. Some patients find that wearing the patch for only 16 hours prevents bizarre dreams. If the patient craves a cigarette when they wake up, they should wear a 24-hour patch. You should not underdose the patient by wearing the same patch for longer than 24 hours, and it is also necessary to use the patch for 8 to 12 weeks and not to stop the therapy prematurely. Patches are available in 15 to 21 and 21 milligram strength. For treatment initiation, the 21 milligram is then tapered down to 14 and a 7 milligram patch. A 10 and a 5 milligram patch follow the 15 milligram patch. Nicoderm CQ product stipulates that the patient should start with the highest dose patch unless they are a light smoker, less than 10 cigarettes per day, weigh less than 100 pounds, or has cardiac disease. This patch should be used for 6 weeks, then transition to a patch of next lower strength for 2 weeks, and then the lowest dose patch for another 2 weeks. Dosage of Nicotrol product is similar to this, 1 patch daily for 6 weeks, then taper down for 2 weeks. The gum delivers nicotine faster than the patch and can be used for incidents of cravings. It may satisfy the oral craving that smokers have. For some patients, chewing gum is a habit. It may delay weight gain because the patient chews instead of eating during the episodes of craving. However, the potential for addiction to the gum is present. In gum chewing, the patient must use proper technique, which is different from normal chewing gum. The patient must chew the gum and then park it in the cheek for greater nicotine absorption. Some of the liabilities of using gum are that it's difficult to use with dentures, it is socially undesirable in certain situations, and the patient should not have food or drink 15 minutes before use. It also requires frequent dosing to control the cravings. Lozenges may deliver, also delivers nicotine faster than the patch, but it's more flexible dosing and can be used in patients who smoke their first cigarette within 30 minutes of waking in the morning. Patients who use lozenges complain of bad taste in the mouth soreness, and dyspepsia. If the patient chews the lozenge, the rate of nicotine delivery is uneven, and the lozenges come in different dosage, 2 and 4 milligrams, and deliver about 25% more nicotine than the gum. The 4 milligram dose is used for patients who smoke within 30 minutes of rising. The others use the 2 milligram dose. Similar to the gum, lozenges are not tapered in terms of their strength. Rather, the patient tapers the number of pieces used daily while adhering to a schedule that is similar to that used for gum. The nasal spray is useful for patients with severe cravings who desire immediate relief. It has the fastest delivery of nicotine and more closely resembles the onset of the nicotine effects of smoking. It has flexible dosing, however, the highest potential for prolonging nicotine addiction when compared to the other nicotine replacement therapies. Nasal irritation is the major limitation and is seen in 80 to 90% of the patients. It may cause mouth and throat irritation. This product may be proved uncomfortable for use, and the patients may take up to 2 to 4 weeks to adjust to this delivery route. Frequent dosing is needed, and the patient must avoid contact with the skin and should wait 5 minutes before driving. Each spray delivers 0.5 milligrams of nicotine. The patient should use 1 or 2 doses per waking hour for 3 to 6 months. Then consider a tapering period by halving the number of doses used each week. For the oral inhaler, the nicotine inhaler releases nicotine when patients breathe through it, and this mimics the action of smoking. This dosage form may be useful for the patient who enjoys handling a cigarette. Patients with reactive airway disease generally are not candidates for this product because of the bronchoconstrictive effects of nicotine. The nicotine patch is usually the preferred route for those patients. Inhaled nicotine is absorbed in the mouth, not the lungs. The nicotine concentrations delivered by the inhaler are approximately 1/3 of those provided by a cigarette. Therefore, nicotine serves to blunt cravings. Mouth and throat irritation is common and is a barrier to compliance. Frequent dosing is necessary. The cartridges must be stored between 59 and 86 degrees Fahrenheit, and each cartridge contains 10 milligrams of nicotine and delivers 4 milligrams. It also contains 1 milligram menthol. The recommended dose is 6 to 16 cartridges per day for 3 months, and these are tapered for 6 to 12 months. Finally, combination nicotine replacement therapy. Initial therapy for smoking cessation relies on 1 form of nicotine delivery, and patients are discouraged from using more than 1 product. For the patient who has difficulty finding the right dosage of nicotine but still willing to try to stop smoking, combination therapy may be suggested. The nicotine patch plus gum has been shown to be effective, spray, inhaler, or bupropion. These combination product schedules must be monitored to ensure that the patient is not overdosing. There's also clonidine. This has been used as a second line for patients refused or cannot tolerate nicotine replacement. Bupropion or other forms. Efficacy is considered limited after initial studies showed promise. Dosage is the same for hypertension. The side effects include sedation and dry mouth. Nortriptyline is a tricyclic antidepressant that has been shown in a limited limited number of trials to be effective for smoking cessation, its effectiveness appears to be unrelated to its antidepressant effect. This is usually started 10 to 28 days before the stop date to allow it to achieve a steady state. The patients usually start at 25 milligrams per day at bedtime and increase slowly to a maximum dose of 75 to 100 milligrams per day. Common side effects include dry mouth and sedation. There has been a phase 2 study of nicotine vaccine has shown that the highest dose tested produced antibodies against nicotine and was associated with higher rate of smoking cessation than the placebo. Quit rates in the study were generally similar to those achieved with other smoking cessation aids. Abstinence rates twofold to threefold higher than placebo were reported. The vaccine is in development, and we should hear more about this in the future. So how do we monitor these patients? The first 2 weeks is critical. Monitor patients closely by telephone. Call within the first week to see how they're doing. Tell them to call the clinician if they're experiencing difficulty. Because most relapses occur within the first 3 months, the patient should be seen frequently in an effort to solve problems and prevent relapse. Because many patients relapse, check on smoking at each visit and encourage patients to try again if they've relapsed. In older patients, monitor for cardiovascular effects, monitor blood pressure, and ask about angina. For patient variables, in hospitalized patients, this is the ideal place to have the patient stop smoking. Patients with cardiovascular disease should be given a decreased dose of transdermal systems to minimize the potential for adverse effects such as body aches and dizziness, and cardiovascular complications, arrhythmias, and MI. For the geriatric patient, transdermal systems are found to be just as effective in geriatric patients. Nicotine patches may help improve memory among some patients with mild cognitive impairment. Pediatrics, yes, children do smoke. The safety and effectiveness of transdermal systems has not been tested in the pediatric population. Therefore, their use in children and adolescents is not recommended. Most of these agents are not recommended for use in patients under the age of 18. However, these children do start smoking at an earlier age, and intervention is necessary. For pregnancy and lactation, Chantix, bupropion, and nicotine gum are considered category C. Nicotine patch, nasal spray, and inhaler are considered category D. Risks to the fetus include spontaneous abortion, low birth weight, anencephaly, cleft palate, and congenital heart disease. These risks are similar to smoking. Pregnant women should be encouraged to stop smoking because of the potential damage that smoking may do to their children. Nicotine replacement therapy should be used only when benefits outweigh risks. Nicotine passes freely into the breast milk, and nicotine replacement therapy may be safer than smoking. Nicotine patches may not help pregnant women quit because the product seems to be cleared faster in pregnant women. This may be related to hormones. For race and gender, the increase in smoking by women since the 1950s is now showing up as a higher rate of death from lung disease among women. Cigarettes cause more damage to African American women than to other populations. African American women show less likelihood of recovery after they quit smoking. In looking at quit rates among certain ethnic groups who smoke methanol cigarettes, Hispanics and Puerto Rican origin were 43% less likely, and African Americans were 19% less likely to quit smoking. There are some drug interactions. Numerous drug interactions occur with smoking, so smokers who are taking a medication that interacts with smoking may require higher dosages than non-smokers. Polycyclic aromatic hydrocarbons are some of the major lung carcinogens found in the tobacco smoke. These are potent inducers of the hepatic cytochrome P450 isoenzymes 1A1, 1A2, and possibly 2E1. The primary pharmacokinetic interaction with smoking occurs with drugs that are CYP1A2 substrates, such as caffeine, clozapine, fluvoxamine, teacrine, and phenolphthalein. The pharmacokinetic profile of inhaled insulin is significantly affected. It peaks faster and reaches higher concentrations in smokers than non-smokers, achieving significantly faster onset and higher insulin levels. The primary pharmacodynamic drug interaction with smoking occurs with hormonal contraceptives and inhaled corticosteroids. The most clinically significant interaction occurs with combined hormonal contraceptives. The use of hormonal contraceptives of any kind in women who are 35 years or older and who smoke 15 or more cigarettes daily is considered contraindicated because of the increased risk of serious cardiovascular adverse events. The efficacy of inhaled corticosteroids may be reduced in patients with asthma who smoke. After a person quits smoking, an important consideration is how quickly the induction of the CYP1A2 dissipates. Upon smoking cessation, smokers who may require a reduction in the dosage of an interacting medication. Some research suggests that smoking cessation studies, methanol cigarette smokers were about 9% less likely to have quit smoking overall compared to those who smoked non-methanol cigarettes. Finally, talking about patient education, patients need extensive education. All drug companies now supply nicotine replacement therapy medications, patient information, and support materials for patients who are trying to quit. For all forms of nicotine replacements, no patient cannot smoke while taking this medication. They should dispose of used nicotine replacement therapy properly. Patches are particularly hazardous to children, and all medications need to be kept out of reach of children as well as pets. For the patch, they need to place a new patch on at the start of each day and wear for 16 to 24 hours. If they wear it for 24 hours, they can wear it for 24 hours if the patient craves cigarettes the minute they wake up. They can wear it for 16 hours if the patient has vivid dreams or sleep disruptions. The patient should place the patch on a new location that is relatively hairless between the neck and the waist every day. They should dispose of used patches carefully. They should fold sticky sides together and insert in disposable trays. They should wash hands after handling these patches and notify their provider if the patient's skin has reactions. For gum, the patient should use one piece at a time. They should begin chewing slowly and should avoid swallowing saliva immediately. They should chew until they've experienced a peppery taste or a tingle. This usually takes about 15 chews. They should then stop chewing and park the gum between the cheek and the gum and leave it there. When the taste or tingle fades, usually after a minute or so, they should start to chew slowly again until the taste or tingle returns. They should stop chewing again, park the gum in a different place. They should continue this until the taste or tingle does not return. This usually takes about 30 minutes. They should use the gum at regular intervals and do not consume acidic foods or beverages, alcohol, fruit, coffee, soft drinks, and for 15 minutes before and during use. Finally, the lounger. The patient must allow the lozenge to dissolve slowly over 20 to 30 minutes while swallowing as little as possible. The lozenge should not be chewed or swallowed. The patient should occasionally move the lozenge from one side of the mouth to the other. A warm feeling or tingling sensation may result.